Welcome to the unit on epidemiology. As we go through this unit, you'll actually find that some of the terms might seem kind of familiar to you now because you've actually been seeing epidemiology play out in real life as we've been studying and tracking the spread of coronavirus through the population. Because that's what epidemiology is. It's the study of diseases in populations. And so some of the terminology we're going to go over throughout this chapter will relate to things you've been hearing about and learning about as you watch the news and as we follow coronavirus. So let's go ahead and get started going over an overview and talking about some of the terminology of epidemiology. Okay, so what exactly is epidemiology? It's really the study of diseases in a population. So whereas medical professionals care about a disease of an individual, so what disease do you have, how do you treat the patient itself, epidemiologists care about the health and disease of the population as a whole. So it's about how are diseases spreading through populations. It's about what is the pattern of disease. So where are we seeing the disease in populations? And it's about frequencies. So how much disease is in a population? Is that different from one population to another? And the reason for this is because if you can understand how the disease is affecting a population, you can better treat that population as a whole to keep everybody healthy. Keep in mind, the spread of disease is called the chain of infection. And this really ties to those steps of microbial pathogenesis. So when we're looking at epidemiology of infectious diseases, there's kind of four main parts. You have to have susceptible hosts. So if we're talking about human diseases, we have to be actually able to get the disease. There has to be a natural habitat. Remember, we talked about the reservoir of the pathogen. You have to have a biological agent, so you have the causative agent of the disease, and then you have those modes of transmission. So how is the pathogen being passed from one individual to the next? The reason we care about this chain of infection in epidemiology is if you can break one of those four pieces, you can stop the spread of disease throughout the population, even if you don't actually know what the pathogen is yet. So when a new disease shows up, if we figure out that it's a respiratory pathogen and it's being passed through the air, you can do things like quarantine and separate people before you even know what the pathogen is to start to break that chain of infection and break the spread through the population as a whole. You can classify diseases based on the amount of disease that's present in a population. So for example, endemic diseases are diseases that are there at a set rate. We know, for example, that there's going to be a flu season every year. We expect to have a certain number of influenza cases. And you can see those cases here. So this black line is kind of the seasonal baseline for what we're going to expect for influenza deaths every year. And you can see it peaks at certain times, that's the flu season, and then it drops. But there's going to be times when we have what you hear people talk about as a bad flu season. Those bad flu seasons are what we call epidemics. So you can see here where our actual numbers were much higher than kind of that average. Same thing here and same thing here. So in 2008, we had a bad flu season. It was epidemic at that time. It's when you have the number of cases or the number of deaths much higher than you expected to be in the community. A pandemic, which you've heard in the news now because of coronavirus, is an epidemic that is spread worldwide. So for example, when coronavirus first came on the scene in China, that would be considered an epidemic disease because at that point, it's a new novel disease. Anything above 0 would be considered an epidemic because it was not endemic to the area, but it was localized to China. Once it spread out of China and started spreading around the world, that's when we now call it a pandemic because it's affecting multiple countries. So keep in mind that diseases can fit into these different categories depending on the time of year, depending on what year it is. It's just because you're an endemic disease doesn't mean you can't be epidemic certain years, and just because it's an epidemic one place doesn't mean that can't convert and change into a pandemic. To classify diseases as endemic or epidemic, you have to be collecting data about the level of disease in populations. And so collection of this data is really called descriptive epidemiology. This is where you're going to be collecting information related to person, place, and time. And so who is infected with the diseases? How many of them are there? Where are those people? So geographically, where are they living? And when is this disease happening? This type of data is descriptive. You're just collecting the information because it's going to be able to identify things like what geographic risk areas might there be, what populations are at higher risk for these diseases, and that's going to allow you to make decisions and use your epidemiological data to actually try to make populations healthier. When we collect this data, there's three main things that we tend to look at. The incidence is considered the number of new cases that happen in a given period of time. So for example, every week, how many new cases of coronavirus have there been? We see this with daily updates. So you can look to see how many new cases happened in Utah today. That's the incidence, hey, how many people just got diagnosed. The reason we care about this number is because it tells you how quickly a disease is spreading through a population. If we're having, when we see those daily numbers go up, it tells us the disease is starting to spread throughout the population, and that's what we don't want happening right now. And so you typically will see these expressed as a number per year, a number per month, or in a situation like we're in right now with an emerging infectious disease, a number per day as we're really paying attention to it. The second value we tend to look at is the prevalence. This is the total number of cases. And so this is looking at not just those new cases, but people who had already been sick. So you can look and say how many people are infected with coronavirus. Those are going to include everyone who's been infected, say, in the past couple weeks. This is the total number of cases. This is going to tell us what extent a disease is impacting a population. And so when we compare, say, Utah's overall numbers to New York's overall numbers of coronavirus, we see a big difference. The prevalence in New York City is much higher than the prevalence here. There's many more cases there. And so from the CDC's perspective, as the country's public health department, they're going to be spending their resources more in New York City than they are here because that's where the problem is. So that's where the population's having the bigger impact. And then the last one we look at is mortality. And mortality is the number of deaths from a disease in a given period of time. And you've seen these numbers being reported for coronavirus also, how many people have been dying from the disease. You'll also sometimes see morbidity talked about. Morbidity is the same thing as prevalence. So in epidemiology, we tend to use the term prevalence. In kind of the medical community, they tend to use the term morbidity for the number of people who are sick. But they really mean the same thing. So here's an example of how we can use descriptive epidemiology to understand what a disease is doing. This is a map of the United States in 2001, and all the little blue dots are a case of Lyme disease. And so just by looking at this, this is prevalence. It's the number of cases of Lyme disease that were reported in 2001, so it's the total people who were infected. But it's also got that geography. So remember, we're really looking at person, place, and time. Who is it? When is it? And where are they? And you can clearly see by looking at this map that Lyme disease is a problem in kind of the northeastern United States. Hiking trails, things like that where I grew up. So I grew up right there, smack in the middle of that Lyme disease land. Hiking trails everywhere have signs posted to check yourself for ticks. Lyme disease is spread through the bite of an infected tick. And so it was just normal common practice for public health departments to educate and advertise and put signs up that say, as soon as you leave, check for ticks because you want to avoid having a tick bite because Lyme disease is so prevalent here. Those types of signage you don't see someplace like Utah because they don't need to spend public health dollars because there is no disease there. So this is why we need to pay attention to where things are happening in what populations. The other way you can look at this is it also allows you to tell what's happening over time. So this is now what the map looked like in 2015. And so you can see in 2001, we were kind of localized to this little region on the East Coast and maybe a little bit out here. But you can see how it's starting to spread out from that localized region. You can see more cases up here. And so this allows you to see how the disease might be spreading through the area over time and where you need to now be implementing, say, educational messages. I picked Lyme disease because this is also an interesting story for me because I was diagnosed with Lyme disease in 2011. But I always laugh that I had to leave New England to actually get diagnosed because I was one of these little dots down here. This little tiny grouping down there in southwestern Virginia is where I lived when I actually got diagnosed. Here's another description of descriptive epidemiology, looking at all three of those main terminology, so the incidence, the prevalence, and the mortality. And so this is data from a while ago, so 2001 to 2005, but it shows the difference between the three. So we have the number of people each year who were diagnosed. That's going to be the incidence. So those are the new cases happening every year. These are the ones that tell you how the disease is spreading. So how much is it actually being transmitted from person to person? And those are the types of numbers that if you're doing educational programs, if you're doing HIV awareness programs, you really want to see those start to decrease. The kind of slight increase from 2001 to 2005 isn't really the direction we want to see that going. It means that disease is still spreading through the population. We also see the number of people who died from AIDS over the time frame. And so when you're looking at those, that's the mortality during each year. And then people living with AIDS, this is going to be your prevalence. And one thing I want to note about prevalence here is that it's a combination of multiple things. So your prevalence has to do with how long people have the disease. So for HIV, you're infected for the rest of your life, which means every year you're now counted in that prevalence rate. It's also going to include how many people were diagnosed, so how many new infections. If you have a rapidly spreading disease and you have a lot of new infections, your prevalence is going to go up because there's more people with it. And it takes into account the deaths. If you have a lot of people dying from the disease, they are no longer living with it. And so that prevalence would actually go down. And so the prevalence is based on a number of different factors that go into the disease itself. So is it being treated? Is it a chronic disease that you now have to live with? Those all are going to be taken into account when you look at those prevalence numbers. So incidence, prevalence, and mortality tend to be the three values that we study and we care about in descriptive epidemiology the most, but we don't typically use them as raw numbers. Instead, we use them as rates of disease instead of just counts. And so a rate is giving you the percentage of a population that's infected. The reason that's important is because if we know there are 100 new cases of disease, that number doesn't mean anything to us. It doesn't really put in perspective of, is that a big number or a small number? If we're going to say that that's 100 out of 10 million people, well, that 100 cases of disease probably isn't that important. Remember, epidemiology is about the health of populations and the spread of disease in populations. So while the disease is probably important to the 100 people that have it, from an epidemiology standpoint, 100 out of 10 million people is a pretty small percentage. But if you only have a population of 1,000 and 100 of them now have this disease, that's 10% of your population. That's now going to be a big deal. And so that's going to be something that the public health department and epidemiologists are going to want to pay attention to. So this is why we're always going to express these values as rates instead of just the count, instead of just the number. And so we typically will do that as whatever the rate is, and then we express it per number of people. And the problem will always tell you how we're going to express that. So is it going to be 4 cases per 100,000 individuals? That's to give context to a percentage. Realistically, most people don't really picture percentages well. So if you tell them 1% of the population is infected, that might not really mean anything. But if you say 1 out of every 100 people is infected, that puts it into perspective. People can picture 100 people and 1 of them being sick. The values mean the same thing. It's just about how you're delivering information to the public. So let's go ahead and take a look at an example of how we would do these types of calculations for rates of disease. So this example says we've got the Happy Valley Rest Home that had 10 new cases of pneumococcal pneumonia that happened in March. The entire month of March had a total of 23 cases because there were some people left over from February who had gotten ill in February and carried that over into the next month. And it tells us that the rest home has 200 residents that were living there. And so you should be able to look at these numbers and say the incidence, so the number of new cases, was 10. The prevalence, the total number of cases, was 23. But remember, we want to talk about rates of disease, not just the total number of counts. So if someone asked what was the incidence rate of pneumococcal pneumonia at the Happy Valley Rest Home for March, the way you would do that is it's going to be the incidence divided by the total population at risk. So that at risk part is important. What it's doing is it's saying we are really only looking at one area, and so we want to look at the incidence rate there. And we're going to be using this Happy Valley Rest Home as the area that we're talking about, and so that's the population. This isn't looking at, say, the entire state or the entire country. We're looking at one location, and so we're looking at the population of that location. So we said that our incidence was 10 new cases, and we know there's 200 residents that are living there, and so 10 divided by 200 is 0.05, or 5%. So there's a 5% incidence rate of pneumococcal pneumonia in this rest home. But remember, people don't really get percentages very well, and so instead of saying it as 5%, we're going to take that number and we're going to multiply it by whatever this per number of people the problem asks you to. So in this case, we'll say we're going to express it per 100 people. So we would multiply this by 100, which is going to give us 5 per 100 people. That puts it better into perspective. You do this no matter what rate you're trying to solve. And so if instead I had asked for the prevalence rate, you do the problem exactly the same, only you would replace incidence with prevalence, which means you would replace it with the 23 instead of the 10. Same thing if something asked about mortality rate, you would replace the mortality number or the incidence number with a mortality number. Now we've mentioned incidence, prevalence, and mortality. When we start looking at rates, though, there's one other value you should be aware of, and that's the fatality rate. So both mortality rates and fatality rates are going to look at the number of deaths from a particular disease in a given time and location. But the difference between them is that population at risk value that you use to calculate the rate. So mortality rate is going to be the number of people who died divided by the number of people in the total population. So for example, the mortality rate for coronavirus in Utah would be the number of people who have died from coronavirus divided by the total population of the state itself. That's different than the fatality rate, which is the number of people who died from the disease divided by the number of people sick from that same disease. So the fatality rate is really telling you the percentage of people who have died from the disease itself. And this is tied to the virulence of the disease. So how virulent is the pathogen and what is the chance that you're going to die if you get that disease? Slightly different numbers, both looking at the number of deaths, but one is more about how is it affecting the overall population. The other is about how virulent the pathogen itself is and what's the chance that if you get that disease, you're going to die from it. So descriptive epidemiology is really called that because it's describing what's happening in a population. You're collecting information and data on the number of cases and who those cases are and where they are, and you're using that to paint a picture. Analytical epidemiology is about using that data to then test a hypothesis about what's causing a disease or what risk factors might be involved in a disease. So for example, if you're finding that one type of group is getting coronavirus more often than another, you might want to understand why. So what are the risk factors involved in that particular group that's leading them to get disease more often? That's called analytical epidemiology because now you're doing an experiment of a sort and you are testing a particular hypothesis as opposed to just collecting data. Now, in epidemiology, there's what we call experimental or observational studies. Experimental studies involve a control group and an experimental group. So they're set up more like you would consider your particular scientific studies. These are really clinical trials. So all the clinical trials that have started for various treatments for coronavirus, where they're trying to say, okay, if we give a group this drug and we use another as a placebo, are there differences in recovery of those groups, or are there differences that we're seeing? Same thing with the vaccine trials. As we start using those vaccine trials, is the people that are getting the vaccine protected better than the people who do not? That's what we consider experimental studies. But most epidemiology is not that way because humans make really bad study subjects. So if you're trying to study risk factors of a disease, it's hard to tell one group, okay, I want you to go smoke a pack of cigarettes a day and I want you to not, okay, to see if smoking increases the risk for a certain disease. That's hard to do and that's not technically ethical. So we do what are called observational studies instead. Instead of making control and experimental groups and telling people you're going to do this, you group people together based on what they already do. And so cohort studies are going to be grouped based on exposure. So for example, if you think that people with diabetes have a higher risk of coronavirus, then what you're going to do is you're going to group people based on those who have diabetes and based on those who do not have diabetes. Okay, so you're going to say, okay, I'm doing this study. I'd like you to volunteer, and you're going to put some people over here in one group, my lovely little stick people, and then you're going to put the people without diabetes over here. And then you're going to look to see the number of cases of coronavirus. And if your hypothesis is right, that having diabetes is a risk factor for getting coronavirus, then you would expect a higher number here than you would in your non-diabetes cases. So that's a cohort study. It's allowing you to make a hypothesis about a specific risk factor or exposure and then study that. That's a little bit different than a case control study. In case control studies, you're actually going to group people based on the disease. So in this case, we would group people that have coronavirus and those who do not have coronavirus. So now we have our study groups based on the disease instead of the exposure. And then what we look for is different exposures. So now we're going to look to see really what differences are there between the two groups. So does the coronavirus group have a higher number of people who have diabetes in it? What case control studies do is let you look at lots of different exposures. So you can take those two groups and compare many different factors. Is the age of the two groups different? What is the health status of the two groups? And these are the types of studies you're currently seeing show up in the news as we're starting to try to understand why do some people seem to get coronavirus and get very severe disease and other people do not. In analytical epidemiology, case control studies are easier to do. So because you can group people based on disease and then look at lots of different exposures, these are usually done first. And then once you have an exposure that you think is associated, then you do the cohort study based on just that exposure. And that gives you more data and more evidence to link a causative link between the exposure and the disease itself. So what do epidemiologists and public health departments actually do with all this epidemiological data they've been collecting, whether it's through descriptive epidemiology or analytical epidemiology? One of the big things is just monitoring endemic disease. And so we know there's diseases present in the population. What are those diseases doing? How are they spreading? You have to be monitoring endemic diseases to be able to identify when there might be epidemics. Okay, when are we starting to see higher numbers than we would be expecting? We do this to try to prevent and control those epidemics. Okay? If you're starting to see higher numbers of, say, influenza, you want to start educating the population that it's probably going to be a bad flu year. You really want to start stressing going out and getting the influenza vaccine. And so these are things that public health departments and epidemiologists can do to try to prevent or at least control those epidemics if they start seeing those numbers start to go higher than endemic levels. This is also how we control outbreaks. So you're collecting data and all of a sudden you see a spike in, say, the number of salmonella cases somewhere. And that's going to be a sign that maybe there's something in the food chain that's currently contaminated. And this is when you start to get those outbreak investigations where people will go in and talk to individuals who are sick and say, okay, where have you eaten? What foods have you consumed? And they can start to narrow down what is currently in the food system that might have the salmonella, and they can pull it off the shelves. Outbreaks are localized increases in number of cases. So they typically are similar to epidemics, but they're not spread throughout an entire country. They might just be a kind of a little blip that then goes back down. You also collect data to determine how effective your public health measures are. And so if we know that there's a disease in a population and the public health has done something to try to prevent its spread, you want to be able to see, is whatever that something you did actually working? A good example of that is something that can be relatively controversial, and this is why we want data to back things up, but the idea of needle exchange programs. So needle exchange programs are where people who are injection drug users can go into a clinic. They typically have other kind of resources there where you have mental health counseling and things like that. But the main purpose of them is to exchange needles. So they can bring in their dirty used needles and get clean ones. Now, this can be controversial for people because people will think it's promoting illegal drug use, but it's really not. What it's doing is it's trying to stop the sharing of needles. And when they've implemented these programs, the rates of HIV in the injection drug community go way down. And so that's part of this using data to see if the public health measure is effective. If they're going to put that in as a public health measure to try to prevent the spread of HIV, they need to be using the data to say, is it working? Especially for controversial things like that. If the numbers aren't going down, maybe we need to find a new public health measure and try something else. And then the last one is to identify emerging diseases, things like coronavirus. We know that this is happening now because of the data that epidemiologists had been collecting. Because of how that data is then reported, we start to identify trends and say, hey, something new is happening that we haven't seen before.